I want to thank this organization for all that you do, for your outreach, for your education, for your convening, and for teaching us to keep patients first and to keep patient issues at the forefront of what we think about and to design them into the studies that we're doing. This has been an evolving process for sure, but I'm glad that you've taught us how to do that. We've also worked very closely with, I think, 11 out of the 12 speakers, and I've now met the 12th speaker here. So I want to thank you all for us being able to help you with all your projects. Some of you were funding, some of you were trying to get money from. One of the things that I want to show is how the government can work for you. We are responsive to you. We get money from you as taxpayers. I want to show you what we're trying to do in return to help you solve three critical questions that all the patients involved in AAKP know about, which is, what do I have? What's going to happen to me? And what can I do about it? I think those are three, and there's a fourth question that comes occasionally. What does it mean for my family? So those are the really critical questions I think that you're importantly interested in, that we are interested in, and that's what this project that I'll talk to you about is intended to try and help solve. If there's time permitting, I have two other projects that I want to talk about. One relates to a later talk, which is a clinical trial network that we're about to stand up pretty soon that's involved in pain treatment for patients on dialysis to try and get them off opioids, which is a critical issue. And the third one has to do with something called e-care that's moving information back and forth with the patient as they go in and out of hospitals to a dialysis unit, to their own provider, et cetera. We recognize that problem. So let's get started. And Richard says that I'm responsible for this project. That is not true. These are the people that are responsible for this project, including 20 patient participant collaborators who come to all the meetings, who have learned about this project, who are actively involved in it, who when they talk about their project, they talk about our project, and they've helped us stay focused on what we need to do. Yes, there are 100 scientists and 20 or 30 people involved in oversight of the project, but it's the patients and their patient panels at every day of all of our steering committee meetings that keep us focused on what the project is. So a quick review, and many of you know this. This is sort of a very, very simplistic version of what nephrology looks like in 2018, in this year. We have two major diseases. They're acute and chronic kidney disease, but as Richard already told us, each of these is really multiple diseases, and there should be S's after each of these terms. For chronic kidney disease, we have two drugs, maybe a third one coming on. We have ACE and ARBs, and maybe SGLT2 inhibitors coming on soon, but that's really all we have. In acute kidney injury, it's actually pretty dismal. We have fluids and tincture of time. And that's it. The reason for the white space around the rest of the slide is that we really have very little else to offer our patients. And this is a complete travesty, and this is what we're trying to do something about. Yes, we have dialysis. Yes, dialysis is life-saving, but we want to avoid dialysis. That's the plan here. So the white space to a drug company can look like opportunity. To a patient, it looks pretty depressing because it means you really don't know, you don't have the therapeutic armamentarium that we need to treat you. So acute and chronic kidney diseases are major health problems. CKD is the other silent killer beyond heart disease. As I talked about, there are few treatments. Drug development has largely stalled, although we're seeing increasing signs of it, because it's hard for the pharmaceutical companies to prioritize the various targets. We understand animal disease pretty well, but we really don't understand human chronic kidney disease, and we have no understanding of what human acute kidney injury is beyond what was studied 40 or 50 or 60 years ago. So we don't know what it is on treatment for ACE and ARBs. The patients want to know, as I've talked about, what do I have? What's going to happen to me? What can I do about it? And what does it mean for my family? What we're looking to try and supply is a more precision medicine-based approach of getting the right approach into the right patient at the right time. That's the mantra. You're hearing it in the cancer field and oncology more and more. Our goal is to try and import this into nephrology. So what could the future look like? Well, the future could look like Star Trek. You could have your tricorder and you scan the patient, and the screen, it pops up, okay, this is what the patient have, this is what it means, and this is what to do about it. Here, take these 2 pills. You will regrow a kidney, overnight. And we have a project like that. It's called Rebuild a Kidney, but it's not going to happen overnight. This is a 10 to 20-year project, but NIH is there for these long-term projects. This is what we do. But what do we do in the meantime? So the future could look like something like this, where you, a nephrologist or internal medicine doc sees the patient, does some simple blood tests, scan the area for what's working and what's not working, and do what they do in the cancer field, a fusion-guided ultrasound or CT, into the areas that look good, into the areas that don't look good, take a biopsy out, and then analyze the biopsy with something that I'll talk about called the Kidney Tissue Atlas. But it's basically saying, here are the cells that we're looking at, here are the areas that look normal, here are the areas that are injured, and we look in those injured areas, we can see that that cell's headed in a good direction, it's going to repair, that cell's headed in a bad direction, it's not going to repair, and what we'll do is we'll tell you of those CKDs, what type of CKD you have, CKD A, B, C, D, E, they'll be called something else, the subgroup, and the prognosis, and give you an idea of what drug, based on the individualized, what's going on in those cells that appear to be heading in the bad direction in some corner of the kidney, what drug should be given to that particular patient. So this is the individualized therapy. This could be the future. This project is to get there. This project we've called the Kidney Precision Medicine Project. It is a long-term project. This is not a drug company 3-year project. We are not pretending this can happen in 3 years. It can't. It will take 10 or 15 years. What we want to do is to understand and treat human kidney disease by ethically and safely obtaining kidney biopsies from patient participant collaborators who have all kinds of AKI and CKD, not just the odd ducks that are that may get a biopsy right now because they don't quite fit into a diagnostic category, but to try and do this for everyone. To find the subgroups that will then tell us what pathways are going on, what pathways are perturbed in the cells that we're looking at, to devise individual treatments. This will do a couple things. It will increase our knowledge base of what human disease is. It will also make the field of nephrology a lot more attractive because we'll have a lot more information to base our scientific knowledge base on, and a lot more scientific opportunities for how to move the field forward. We hope that more young people will come into nephrology because we'll see this as an area of opportunity to study, because it will be based on human disease, not cell lines, not animals. And improve the pipeline of drugs, obviously. Now, to get there is not going to be easy, and we need a bunch of culture changes. And we're going into this project, we hope, with eyes pretty wide open of what's needed. So there's a lot of technology challenges, which I will talk about. But that's probably the easiest part of it. The harder part is to change this culture around biopsy, because nephrologists stopped doing kidney biopsies in most patients with CKD and all patients with AKI about 40 or 50 years ago, because we had the hubris to think we knew what we were doing. That turned out to be a bad decision and has led us to this vacuum of information where we are right now. This project has to change that into making a biopsy useful to obtain, because what I really want is the patients, you guys, to go to your nephrologist and demand, I want a kidney biopsy. How come you're not doing a kidney biopsy? That's where we need to be. But to get there, we need to develop a new pathology that makes the biopsy useful. We need to have the subgroups and individualized treatments to make that information, to make the biopsy worth doing. That's what's going to drive this whole process. It involves new pathologists, new nephrologists, and patient understanding of what we're doing. It's all linked and will require some funding. So this is a kidney biopsy. How many of the patients in the room have had a kidney biopsy, either to your own kidneys or your transplanted kidneys? right? Quite a few. How many have had that to your own kidneys? Fewer. Okay, so that's kind of typical. In glomerular disease, we biopsy that because we think it will influence what we do. In chronic kidney disease, we haven't been. This project wants to change that. So this is what a kidney biopsy looks like. It's usually done under ultrasound guidance. There are some risks. There's some risks of bleeding. There's a tiny, tiny risk of death, but we have to acknowledge it and be frank about it and honest about it. We've talked to a variety of patients, researchers, ethicists, et cetera, at a meeting a couple of years ago to go through the ethics of a kidney biopsy and of doing a research biopsy, kidney biopsy. And it is ethical if done safely, carefully, and with the understanding that you're going to probe that kidney tissue and get all the knowledge you can out of it. And we think right now the balance has changed, the technologies have changed over the last couple of years, that we can get more information out of that biopsy than we could before, and that's what makes this project possible. So the goal here is to create a culture where the clinical biopsy provides useful information to target therapy. This is what a kidney biopsy looks like when you look at it and take a thin slice and look at it under the microscope. We stain with a couple stains, and we do essentially one color imaging. That's it. What we'd like to do in the future is have it look something like this. Okay, I pulled this off the internet, full disclosure. but the idea is don't just stain for one or two things, stain for 10 or 20 or better yet, 40 things. That's the target that we're trying to get to. There are some technologies that maybe can stain for 60, 80, 100, even 500,000 things. That's a few years off, but the technology is moving so quickly that we think we're actually going to get to the 40 very, very quickly. I mean, there's a paper in Science that has done this already, but one paper does not mean it's doable. Okay, so we want to build something called a kidney tissue atlas. What's an atlas? Well, an atlas is a collection of maps. So this is about building maps of what is where. Usual atlas shows you, what countries are where and who's the leader and how many people are in it and their economy, what does it look like. What the kidney atlas will do is we'll have multiple maps that show us the architecture of the kidneys, what cells are where are the blood vessels, those are the forgotten component in the kidney, what are the structures there, how do they work. That's been the real bugaboo. That's what we want to get to. And the interactions between the cells, that tells you what's there, but what we want to know is more of what does it mean and how can I treat what's gone wrong. This is what it will look like. Again, I pulled most of these off the internet, so they're somewhat random, but one of them is real. You can tell me later which one. But the idea here is to analyze single cells, one at a time, to find the markers. What markers will mark the individual cells in the kidney? So we're not like the radiologist saying there's a problem here in your heart somewhere. It's that cell's causing a problem. What is that cell thinking about? How do the areas look different? This part of the kidney looks okay, but this corner over here doesn't look so good. That's the part that we're worried about. That's the part that we want to target. And what's that cell thinking? And we may need, in some cases, 3D imaging, the last two on the bottom right, because parts of the kidney, particularly the blood vessels and the glomerulus, are very hard to see on a single thin section. You have to stack them up to be able to figure out who's talking to whom and where the bad signals are. Now, the next couple of slides get a little bit technical, but I want to introduce them with this leaf. So this is a leaf. You're out on a hike, and you brush up against it, and you wonder, I wonder what that was. So you can go to the internet and Google leaf, and the internet will tell you what that leaf is made out of. That there's, it's got a stem, and it's attached to a tree, and whatever. And here's where the chlorophyll is. But that's not the useful information. What you really want to know is, what does it mean that I brushed up against this leaf? That's the patient outcome piece that takes years to collect. So you go to a leaf identification card, and it tells you, well, this is poison ivy, and you just touched it, so you're likely to itch. But if you don't want to itch, maybe you ought to apply some topical steroids. So it's this leaf identification card that this kidney tissue atlas is trying to make. It's not just what is where. We've done that, and we're doing that. It's what does it mean. So here's the technical part. What we do is we take the tissue, we break it apart into single cells. That tells us what's where. We get some markers. But the harder part, the right-hand part of the slide, where we put everything back together with patient information from following the patients for a couple of years or 5 years or 10 years, which is what it takes to understand the trajectory of some patients with both either acute or chronic kidney disease and correlate with the clinical outcomes. That's the part that we're trying to figure out how to do. I'll be honest, we know how to do the left part. The right part is still a bit of a mystery, but we think we know. We have a first approach to it. Okay. The idea here is a basket trial to individualized therapy to say, okay, you have this kind of kidney disease, you need this therapy. You have this kind of kidney disease, you need some other kind of therapy. This is being done beginning, or there's a project we're about to get where people are thinking about doing this in glomerular disease. We want to move this to the larger issue of chronic kidney disease and acute kidney injury. The organization looks something like this. There are, at the moment, 6 funded recruitment sites, 5 funded tissue interrogation sites that interrogate the biopsies, a central hub that gets all the information. NIH, NIDDK is putting in about $7.5 million. It's actually closer to probably $8.5 million or so per year into this project. And we are looking for help. We're looking for help from pharma and from various other groups, because although we have enough to get started, we probably don't have enough to get to the full scale of this project. Now, the important part of this project, as I've mentioned, is keeping the patient front and center. And this is our first project where we have engaged the community. We've engaged a couple of you in the room to help us. Many of the patients that were with you yesterday were also part of KPMP. And what they do is they tell us their stories. They keep on reminding us why they are in this project, why we need to move faster. They can convey to us their experiences, inform us on why research is important, and make sure that we do the right things. And they have already shaped part of this study. They've done the obvious thing. Well, not so obvious. They've written the first draft of the informed consent document, that 30-page legal thing that nobody understands. They've tried to force us, and they've helped us write it in English so they can understand it. They now want to write it over a 1-page summary of it with figures and diagrams to make it completely understandable to patients. That's terrific. The other thing that they've done is they've forced us, and correctly so, to figure out, since this is a research biopsy, if 1 or 2% of the patients have a bleeding episode, the patient shouldn't pay for that. The study should pay for it. So we're now in the process of trying to find insurance to cover that, and have found it and are working through the fine details and hope that some of the people in the room will help pay for that, because the government can't pay for that kind of insurance. But other people are stepping up to do it. Again, they keep us on track, and there is a whole subgroup, the KPMP Community Engagement Group, that does this. Richard leads it with Kathy Tuttle. And they're also working with us on payment for lost work and return of results. So these are things that are critically important for a study to do, and we want to do it properly. And getting immediate feedback, that looks good, not so good, has been really very helpful. This is the first of 2 studies, this one and the Apollo project, where we're doing this, and it is making a difference. And Paul Conway, where he did, has devised the first stab of the communication plan. He did it on the back of a napkin. Thank you, Paul. Or maybe a piece of paper. And we know that that this is going to be largely work by word of mouth. The patients are going to help us recruit other patients into this study. It is unique, certainly in our institute and across NIH, to do it this way, and we hope that this is the model of the future. The other piece is we want to try and convert this into a patient public-private partnership. We're involving all elements of the renal community, because we have enough to get started to do the pilots, but as we scale up, we're going to need more funding, and we have some ways to do that. So we need your help. So there are 2 other projects I want to talk about. The first relates to one of the later talks on pain management. I didn't realize that AAKP had been involved in getting some money to NIH to work on the pain crisis. So I want to thank you, Paul, for doing that. It turns out that NIDK applied for some of that money, and we got it. So we will be doing a study of pain management in dialysis patients. So background. As many of you know, dialysis patients have a lot of pain. And when you do the studies, and people in my group published a New England Journal paper maybe 6 months or 12 months ago exactly on this topic, the dialysis patients have pain, I think it was about 5 or 7-fold more prevalent than the rest of the United States population. So it's a big issue. And what we applied for and got is money to do a large study in dialysis patients of improving pain management. The details of exactly what we're going to do and how we're going to do it are yet to be worked out, but we'd appreciate some feedback from you folks of how to do that. We'll be having a meeting soon where we will be asking that question of, now that we have the money, what exactly do we do? So that's Project 2. Project 3 is something called eCare. And I've seen this with my own father, who was hospitalized for pneumonia, came out of the hospital with about 60 pages of stuff, of which 60 pages were complete gibberish and garbage and not worth anything. What we think is needed is when patients move back and forth from one healthcare provider to another, to have a package of information that has what they want. You know, if you're chronic kidney disease patient heading towards dialysis, if you've decided you want this kind of access and this kind of dialysis or this kind of transplant, then that information should be able to travel with you. So this is a living document that would have the patient decisions that have been made, the important patient information, your diet, nutrition information, all kinds of things in it, viewable from a patient, from a healthcare provider, from a nurse, from a psychologist, whatever, anybody helping you. And we've assembled a team to be working on it. It's actually going quite well. We've had to come up with some new, the sort of dictionary kinds of terms for interfacing with EHR. We've actually been doing that. We've gotten the pipelines worked out. It's in pilot phase now to be tested. And we have in the process of applying to money from the POCR, the Patient Oriented Research Initiative Trust Fund. Somebody's going to be talking about that later today to get money to actually finish up this project. So we're really excited about it. Richard and others have helped us think through it. We think it's going to be helpful not just in dialysis patients, not just in CKD patients, but across the board to people like my father who, you know, you leave the hospital and you want to know, what should I do? And that's what will be in it, not 80 pages of complete garbage. You know, Richard, you were just in the hospital. I'm sure you got that, right? You got that stack. All of the patients in the room who've, been in and out of hospitals. You know what that looks like. And this is to try and make it actually useful to you and to everyone. Because your health care, what we know, and I know this from taking care of dialysis patients in the past, is that you go in and out of hospitals, and nobody knows exactly what happened, and you have to call the hospital, what really happened. And we need some way of exchanging information, because if we can't do that, we're going to continue to have problems. So those are working on many, many, many projects, but those are the three that I thought I would highlight.